Dr. Luke. It is so great to have you here. You are doing pioneering work. I would love for everyone to know what exactly it is you do and to tell them that you are going to be one of the speakers at Endofound's Patient Day that is upcoming this month.
Diana, first of all, thank you so much for inviting me to EndoTv. It is my pleasure and honor to be part of this cause. I'm Dr. Janelle Luke. I'm the medical director here at Generation X Fertility. Very excited here to talk about endometriosis. I personally have struggled with endometriosis in my career, in my life, own life, and it has been my research in medical school also was dedicated to endometriosis. So I'm very excited to talk about this, some of the new findings and some of the things that I do with my patients.
For those that don't know, endometriosis is one of the leading causes, if not the leading cause of infertility. Why is that?
Endometriosis is a very difficult disease to diagnose. So that is a big problem because now you have patients with quote unquote pelvic pain and our average conversation with our moms, with our girlfriends, or oh, my period is painful. It was, just take some Advil, take some Motrin, take some Tylenol. And that is usually the comment, right? And or suck it up, or you do it silently because you want to get through the day and work. And so that pain, no one become empowered and talk about it. It becomes a symptom that you kind of recurrent and then you put it under the pillow. I guess it's like things you see at the house is always annoying, but you don't really address it, but they become a constant. And so that's number one. Then let's say you bring this to the doctor, they will say, well, it's part of you. Hey, it happens to average women. Women have pain during their period. It's very common. And they may not even ask you further issues or common symptoms that are associated with endometriosis, such as, do you have pain during your period? Do you have a family history of endometriosis? Do you have pain during sex? So now with all those history, you will create more highly that you may be diagnosing with endometriosis. But then the doctor may say, you may ask the doctor, how do you diagnose endometriosis in me? Then the doctor said, well, the really gold standard of diagnosing endometriosis is that we will have to do a surgery on your belly and to take a look inside. Now, once you say that, patients also be like, what? You need a surgery to diagnose endometriosis or to treat? It becomes more invasive, but that it was the gold standard. And Diana, I know we are going to go into, are there blood markers? Are there MRI? Are there ultrasound? Is there more non-invasive ways? Yes and no, because endometriosis also may not show on ultrasound on MRI. So the only way to really, again, go standard diagnose endometriosis is laparoscopy. But there are innovative testing. We may talk about it later on to diagnose endometriosis, but that is not yet a standard across the nation.
So we know that endometriosis takes an average of 7 to 10 years, if not more, to diagnose. We also know that it affects 1 in 10 born with a uterus in the United States alone. That's probably a bigger number because that's just who we're reporting. But how exactly does endometriosis, let's say, for lack of a better term, attack someone's fertility? Does it admonish the egg reserve? How exactly does fertility get taken away by this disease?
So there are two angles of it, because I always tell my patient, you need sperm, you need egg, you need a tube, you need uterus to get pregnant. So 4 things. Sperm, obviously, woman is having endometriosis may not affect the sperm, so we'll put the sperm aside. But then how did that affect the uterus? How does it affect the egg quality? And how does it affect the tube? So let's talk about the origin of endometriosis first. So this is also a controversy. There are about 8 different causes, actually more than 8 possible causes of endometriosis. But back in 1926, Sampson's theory is the retrograde bleeding of endometriosis, where bleeding is supposed to go through the vagina and coming out in the menstruation when women having their menses. However, there's a percentage of blood can backflow through the tube into the belly. Which has happened to 70 to 80% of us women. However, there's about maybe 10 to 15% of us do not clear the blood every month. So that there's accumulation, keep on backflowing the menses into the belly, Again, majority of them should be cleared by your belly, but the belly does not want to clear it for some women. So now this is where the thinking can happen, is that there may be a high inflammation state inside this woman's belly that is not allowing them to clear the endometriosis. So that's one theory. Second theory is that cells within our belly is kind of what we call metaplasia, change into endometriotic cells. So now those are the origins. So how did they attack? Well, if there's some inflammatory or inflammation environment inside our abdomen, does it affect our tubes from moving? Oh, I always like my little doll here. Does it affect the tubes from propelling the eggs to go from the ovary to the uterus? Because supposedly the egg has to meet the sperm right at the tube, and then the sperm and the egg would then migrate inside your uterus. So that's one attack. If the tube is now getting inflamed and not as flexible to move the embryo or the egg, it will be a problem. Second, can it affect the uterus receptivity to the embryo? That's attack as an inflammation to the uterus. So there's some theory that you need certain molecules to be highly regulated before embryo can be implanted into the uterus. So if you have a high inflammation environment, those molecules downregulated. So that has been proven. They are downregulated. So implantation become difficult into the uterus. Then there are other theories such as equality because of the inflammation environment around those ovaries. So, and when you are retrieving eggs, are they in bad quality? So in the past, the treatment of this, I'm so sorry, Diana, I'm kind of, you didn't ask me that. You just asked me about inflammation.
This is great. No, please go, because egg quality is so important, especially when you're dealing with chocolate cyst endometriomas, which can directly impact egg quality.
Yes.
It can attack the ovary.
Yeah, so when there's inflammatory around the ovary, thank you for elaborate that. You can form endometriotic cysts around the ovary, and that may sometimes suppress the production of valuable eggs. Second, you can also cause this inflammation where the egg quality may not be as great to the eggs quality in the ovary. So in the past, people think IVF may be a great treatment for it because you just get the egg cells, the minimal surgery. However, when the egg quality or cannot produce better blastocysts, so for certain patient, endometriotic surgery should be first before IVF, because you may want to clean up the abdomen. Now, it is a tough call. I do have lots of tough calls for a patient who come in. I know they have endometriosis. I see endometrioma. Now, this is fascinating. They don't feel it. They don't feel anything. I'm like, oh my God, you have a big chocolate cyst on your ovary.
And is that considered what is known as silent endometriosis?
That is what we consider the silent endometriosis. That is correct. And then now how do you convince a patient suddenly to go for surgery? They're like, wait, I'm here just for a baby. Why are you making me to do something that I don't even feel? Then there's also the easy call, we call the patient. They're in very bad pain. They really want to get pregnant and they're having trouble getting pregnant. And I said, well, you're going to do some ovulation induction, or, we'll give you Clomid and letrozole to get you ovulating, but you may not get pregnant this couple months. And then you see her struggle. You're like, you know what, maybe you should talk to the Dr. Sheshkin or any other endometriotic specialist first, because this 3 or 4 months of dealing with this, I can't watch you suffering pain. But then the worry is that when they're cutting the chocolate cysts out or when they're operating, they worry about the decrease of ovarian reserve. So it's not easy. It's like back and forth, kind of like, how do you have a patient-doctor decision that can be made that can situate that patient that moment? So endometriosis is not easy for diagnosis or for management for infertility.
What was interesting to me when I had, years and years and years of menstrual suffering. And I was ping-ponged around to different doctors who not a single gynecologist ever said endometriosis. It was, you're prone to ovarian cysts. We don't know why they're bursting. We don't know why you're in so much pain. We don't know why you bleed every 2 weeks or so heavily or any of that. But it was given a birth control Band-Aid and I was sent on my way. And it was just kind of like, well, I drew the unlucky straw, right? I just get bad periods. Some of my friends don't. And that was all it was. But by the time I was diagnosed, I started my menstrual cycle at 11. By the time I was actually diagnosed, I was 32, and it was a specialist who saw something in the transvaginal ultrasound that she said looked like a mass in my uterus. She didn't know what it was, but she said, I have a very strong suspicion it's endometriosis. I am going to test your anti-Müllerian egg or your hormones. I want to do a simple blood test. I have a feeling that if it's diminished in any way, you definitely have endo. Either way, you have to go for a surgery. So that was the first. But what I was surprised is here I was 32 years old and my egg reserve was that of someone who was in menopause. It was that low. So why, I mean, if it's not caught early, it really can go for the egg reserve, correct? Endometriosis?
Yeah. So if this is interesting, there's no data right now is how long a patient suffer with endometriosis and how long this may affect in terms of the quality of the egg. So we don't know because we supposedly endometriosis is when you're born with it. A quality or quantity you're born with it. But
Right.
how does that affect as in the duration of the diseases because it can be silent. And where the location. So endometriosis, some people have it in the bowel. They don't have it in the ovary. They don't have nothing. They only have it in the bowel. They don't have it in, they have no cysts. Not everyone have chocolate cysts. And that's why we were saying MRI and ultrasound may or may not able to diagnose endometriosis because majority of patients do not have chocolate cysts.
Interesting.
About 15 or 20%. Endometriosis can be dispersed. Lesions can be everywhere. But then the worry is that what will happen if you start operating on the chocolate cyst, and this where finding a great surgeon of endometriosis to not diminish ovarian reserve is something very, very important.
Right. Yeah. And that's why I'm trying to understand the correlation between endometriosis and infertility and egg reserve, because, that was something that I've heard not only from my story, but from a lot of different endo patients. That they were surprised to learn that because they didn't get early diagnosis or early treatment, the longer it progressed, the lower their egg reserve was. Now,
this is interesting. This very interesting. No, yes, this is, but yeah. So is it correlation or causation? This one I don't know because why you have lower reserve, but that is a very I can totally see it's possible, but this is also interesting. Is majority of patients who are diagnosed endometriosis, they had surgeries. Some of them, when I was in the endometriosis clinic at Yale, where I was practicing, patients are having like every 3 years, and from like teens to all the way to the 30s. So that's also correlated. So now I would assume the collateral blood supply is much less to the organs, and that may decrease in ovarian reserve.
And in my situation, I did have chocolate cyst, like reoccurring. So that probably was why. And I didn't have previous surgeries. It just, was kind of swept under the rug. So that does make sense. Is there any way to prevent infertility for those with endometriosis? Is there anything that you can possibly do?
To prevent infertility, the only way really to do this is to, I'm so sorry to say this. So endometriosis is an interesting disease also. And also not just that, any infertility diagnosis, adenomyosis, endometriosis, PCOS, I've found this very interesting. It may not affect you at the age of 25. So everyone has the same diagnosis, same stage of endometriosis. You can still have a baby, majority of us at 25. But once you get older, the fact that you have endometriosis, plus you got a little bit older, I'm talking about like 31, 32, then your fertility potential suddenly drop much lower. So now the age factor comes in, but it's not because just age, because other 31, 32-year-old girls can get, women can get pregnant. So it's the endometriosis factor that causes them to have this disease. So the way to prevent, sorry, I know I'm sound very typical for older patients or parents that, well, just get pregnant and have a baby early. So that is one way, is that when you are diagnosed with endometriosis, and I remember during residency, I told you I got diagnosed, my mentor was like, Janelle, after I woke up in the recovery room, so I just get pregnant early. And I'm so glad I did have a fiance or boyfriend, and we met at college. So, but I'm wondering if I was single, how, and then there's the talk of egg freezing, obviously, that now
I want to get to that too as well.
Yeah, so that will be, but in terms of preventing it, I don't know. I mean, I know people are doing birth control pill, but those are all symptoms. It doesn't change the progressive disease. Now, I love East and West medicine. Some of the thinking I have endometriosis that it produces what we call prostaglandins.
Yes.
I'm not trying to provide a diet right now to stop. I don't think I can. I haven't proven data for that. But an antioxidant diet with lots of berries, like no gluten, can really sometimes help with certain disease in our women's organ, like fibroid. And so I really ask patients to sometimes cut out their dairy, milk, meat, things like that is very important for
because that
improving
all
diet.
links to inflammation, right? So
Yes,
because that was one thing I keep hearing when we're talking to endo patients is I had to change my diet. And I know for me that if I stick to what is an endo-friendly diet, I feel so much better. But as soon as I go and eat the processed, let's say McDonald's, I feel it. It's just the body responds very quickly for me to any kind of swelling, inflammation. I guess it's the autoimmune capabilities of endo, which makes a lot of sense.
Yes. So this is just, yeah, I love that. I think a exercise and regimen, I've seen that it has helped tremendously and significantly for a patient. So
now we touched upon egg freezing, and I am not a doctor, but being that I've seen and heard firsthand stories of those who they've had either diminished egg reserve or they have completely become sterile, and they've had to use egg donors. They have mentioned, that they wish they could go back in time and they froze their eggs, that they would have just frozen them as soon as possible, as young as possible, so that they could have had healthy, viable eggs. What is your stance on, and let's just say you got diagnosed with endo, do you just go and freeze those eggs if you can?
Yes, I recently helped 2 patients or 3 patients where they got recently diagnosed with endometriosis. Before the surgery, they came and do egg freezing, again, because of their youth, because we talk about how endometriosis can sometimes affect the quality of the egg. But this patient is like 23, 24. Wow. With diminished ovarian reserve, interestingly. So you were saying, hey, Dr. Luke, maybe both are hand in hand, and there's some new data coming out. Do they become more aware, so then they go, or they do more birth control pill? Like, how does that affect the AMH value? But I think there was some data on endometriosis ovarian reserve, but this patient also have a less reserve, but at 23, they're fine. Again, 23-year-old, doesn't matter you have only 3 eggs, 2 eggs, you can have twins because of the youth, because the quality, you don't need 6 eggs to get to 1 baby. You need 1 egg and 1 baby. So for her, she did her egg freezing. Then she did the endometriosis surgery because she was worried, and the surgeon himself is worried that after he does the surgery, she may have much more diminished. So she just froze all her eggs during this here.
Very interesting. I have one final question for you.
Yes.
Regarding, I've also heard that if you have a successful endo excision surgery, that sometimes you'll see a improvement in in the egg quality. Is that, or am I?
Yes, no, you're absolutely right. So IVF, IVF is not never, when you have hammer, everything's a nail. So I'm an IVF doctor. I know Dr. Shashin is an endometriosis surgeon, and many other endometriosis surgeons are, they don't go into IVF yet, because it is true. If you have mild to moderate endometriosis, if you are just doing endometriosis surgery, it's supposed to have an improvement of 3 to 5% of fertility. Either inflammation decrease, either the tube may be moved, like we were talking about the origin, how endometriosis affect infertility. That would be one way to help, because you decrease the inflammation environment, the tube is moving well, the egg quality is better, and that follows. But again, this is where the counseling, and when patients not have, we mentioned about the silent endometriosis, they may not be as excited to go to surgery. And there's also other papers that have shown IVF supposedly is help on certain level of endometriosis patient. And this is where the variability and patient's emotional state and physical state and counseling is so important. One, I just told you how hard it is to diagnose endometriosis. 2, there are different stages of endometriosis, and there's also variability because there are different surgeons that stage it yes, there are guidelines, but it's not clean because you may, some surgeon may say something, some surgeon may say something. We've seen it. There's variability in staging. And then there's also variability in patients' experience with endometriosis. There's silent. Silent means nothing.
Right.
Means you any woman, they're like, I'm with great periods, they can have endometriosis. So that is make this diagnosis become so difficult, and that's why you get back to what you said, 7 to 10 years to make a diagnosis. Isn't that how horrible?
Right. Yeah. I'm very glad that there's people like you, especially someone who has lived with endometriosis, understands how disruptive it can be to so many aspects of your life, and that you've put your passion into helping others that suffer from diseases that can diminish their equality, that can stop them from becoming the parents that they want to. And I know you don't just treat endometriosis. You mentioned all the other ones before about PCOS and all other kinds of reasons that could lead to infertility. So I know you're making a lot of people happy becoming parents and helping them on their way.
Thank you so much, Diana. I truly thank you for having this opportunity to talk about endometriosis. So thank you.
Thank you. And we'll see you at Patient Day.
Yeah, see you at Patient Day.